So obviously the task was to say that cardiovascular disease management for diabetics in Ramadan is something that is of great importance. The magnitude is very large in terms of the Muslim population and in terms of the large number of diabetics that fall into the region here with diabetes. Now, obviously for this audience, we won't go into the details of Ramadan. I think everybody's kind of familiar with it, but the key point is that there is a difference in the duration of the fasting time and can be up to 20 hours in certain climates. And that means there's more risk of the exposure to hypoglycemia and dehydration. Now, Muslims are not obviously the only communities that fast. So obviously Orthodox Christians abstain for certain foods during Lent, for example. Baha'is also fast, Hindus and Jains. So there's a lot of literature on this, but of course the greatest body of literature actually systematically comes from the Dar consortium. So one of the important points that we wanted to talk about is the difference in the physiology of fasting between healthy and diabetic patients. So clearly we will have in the healthy patient low plasma, low glucose, which leads to reduced insulin secretion. There's going to be fatty acid release from the adipocytes with generation of ketones that go into the liver, muscle, and adipose tissue. There's going to be increased glucagon and catecholamines, more gluconeogenesis and glycogenolysis, which depletes the glycogen stores. Now, in the diabetics, there may be a failure to increase of the glucagon in response to hypoglycemia. There will be excessive glycogenolysis and gluconeogenesis as well, which may lead to, in fact, hyperglycemia. More ketosis due to the insulin will lead to ketoacidosis. So these are the two major issues that differ in the diabetic patient. Now, going back to the point of Ramadan fasting, fasting does not apply to all adult Muslims. So from a religious standpoint, if it's detrimental to the individual health, Quran states that fasting should be avoided because Allah intends every facility and does not want to put you into difficulties. This is not just a simple exemption to fast. As Prophet Muhammad said, peace be upon him, God likes his permissions to be fulfilled as his will to be executed, which is what is called ar-rukhas. So one of the important Islamic doctrines is that fasting that exposes health to possible hazards is not in accordance with jurisprudence. And therefore, in most cases, and this is the guidelines, to do a medical checkup before Ramadan, particularly in cardiovascular disease, patients with diabetes and renal disease. This is finally a discretionary decision to the treating physician, which means that we have to have a lot of responsibility and ownership as to what we advise their patients. So coming back to the patient at hand. So there is a lot of data actually about patients with stable coronary heart disease. And the basic rule is this: patients with stable coronary heart disease can observe the fasting of Ramadan without anticipating any major adverse cardiac events, while those with unstable disease or recent or pending revascularization should refrain. Most importantly, the incidence of acute myocardial infarction has not been shown to increase during Ramadan, no increase in hospitalization with heart failure, and in general, most cardiac medications can be adjusted to once or twice a day to fit the fasting schedule. So there are actually some studies, which I will have the counter argument to my esteemed debater, Professor Inas. In fact, most of the studies have suggested that Ramadan fasting is safe in patients with stable coronary heart disease. In fact, Ramadan fasting reduced the pro-inflammatory markers significantly up to 4 weeks after Ramadan, denoting a potential long-term benefit of Ramadan fasting in pro-inflammatory markers. Most of the studies actually followed the patients for 4 to 12 weeks after Ramadan as well. And in fact, this is maybe why intermittent fasting has become very popular. So coming to the case that was shown by Professor Hassoun in our initial introduction, this is a patient who, by every definition, of course, you might be familiar with this, the IDF DAR score, the patient is not frail, the patient has stable cardiovascular disease, the patient's glycemic control is reasonable, and has had no problem in previous symptoms. So this is a low-risk patient, and I would say based on the diabetes guidelines, this patient can fast. Cardiac risk factors in Ramadan are also modified. Weight loss occurs during Ramadan fasting, and if it maintained, can be beneficial to patients. So they should be encouraged to preserve it, particularly if they have metabolic syndrome and hypertension, diabetes, and obesity. And smokers should be encouraged to stop smoking. There are several studies that showed actually during the period of Ramadan an improvement of the 10-year cardiac risk factors based on the conventional risk factors. There were significantly higher HDL, lower LDL, blood pressure, BMI, and waist circumference after Ramadan. So these are all beneficial to the cardiovascular system. In addition, endothelial dysfunction, which is basically the loss of nitric oxide bioavailability, is a well-known cause of cardiovascular disease. Now, diet and fasting actually has an impact on endothelial dysfunction. So this small study actually from Yousefi's group showed that nitric oxide levels were significantly higher after Ramadan fasting compared with the baseline value. And smoking. Many public health authorities used Ramadan's initiation of Ramadan to spur smoking cessation. And basically, if they abstain during the daytime, then this is a training to abstain later on. Enforced smoking cessation during daylight, during Ramadan, due to laws, can actually make it easier for people to start this process. And of course, after the Ramadan is done, of course, most people go back. However, this is an important way to encourage people to smoking cessation. So again, an indirect benefit in terms of cardiovascular disease. Lipids improve during Ramadan fasting. So these are studies on healthy male volunteers. Here we saw a significant decrease in cholesterol, triglyceride, and LDL, and an increase in HDL-C. Dr. Abdullah Shahab from UAE University also showed significant improvements of lipids and lipoproteins, all of them positively towards the end of Ramadan, and a progressive increase in HDL and LDL even a month after Ramadan as well. Weight in Ramadan is a little bit controversial. However, almost all the studies showed that there was a uniform weight regain after Ramadan, sometimes because of the feast. So those patients who maintained the weight loss may have had a different metabolic profile. Generally, the weight loss, though, is transient. Satiety during Ramadan. So this is another important point. Large meals during suhoor and iftar can lead to glucose spikes. Large nighttime meals after long periods of fasting may, in fact, cause adverse events, including hypoglycemia and hyperglycemia. However, utilizing GLP-1 therapy in some small studies may reduce feasting while breaking fast in some patients with diabetes during Ramadan. So preventing these large spikes during Ramadan. So coming back to the point that was stated very nicely by my colleague, Professor Inas, about the platelet effects in Ramadan. So actually, the bottom line is, does this physiology in the lab translate into cardiovascular events? Well, actually, the answer is no. So several studies have actually looked at Ramadan fasting and any effects on acute myocardial infarction or acute coronary syndrome. In fact, Ramadan fasting decreases the number of admissions for ACS, AMI, and unstable angina. It does not increase the burden of acute illness. And in studies from Dubai and Iran and Egypt and Qatar, the actual incidence is similar to the month of Ramadan. This study from Iran looked at the effects of Ramadan fasting on coronary heart disease patients, frequency of acute MI and unstable angina events before and after Ramadan. About 1,600 patients over a 7-year period, actually lower in Ramadan than before or after. So it clearly does not increase ACS events in spite of the pathophysiology that was very nicely described on the platelets. Jassim al-Suwaidi, who runs the cardiovascular center in Qatar, looked at the database of all patients admitted to the cardiology department at Hamad Medical Center. In fact, 95% of the patients were fasting. The patients presenting with ACS over a period of 10 years, 20,000 patients, 8,444 were Qataris. No significant difference in acute MI or unstable angina before, during, or after Ramadan. And this other study from Turkey showed that the admissions with specific complaints to emergency room did not change during Ramadan as opposed to before that. So no increase in acute cardiovascular events. Now, you're going to find this study very interesting because this is from a group of physicians on primary PCI, stenting, in which antiplatelet therapy is absolutely critical. So if we look at this very carefully, These are patients who had post-PCI and either ACS or stable coronary artery disease who were given dual antiplatelet therapy. The conclusion, low-risk patients with normal systolic function who underwent PCI may Ramadan. However, Ramadan fasting after an acute myocardial infarction and a PCI for unstable angina or non-STEMI may not be safe. So if we exclude the first 3 months after an acute MI, everybody else who has coronary artery disease, even if they've had a stent and even if they're on antiplatelet therapy, may continue to fast. What about congestive heart failure? Again, congestive heart failure does not seem to increase hospitalizations during Ramadan. Again, the group from Qatar, 2,100 Qatari patients with CHF, no significant difference before or during Ramadan, no change in functional class or any hematological or biochemical parameters during Ramadan. Now, the caveat is both patients with decompensated heart failure or those on large doses of diuretics because of the fluid restriction are strongly advised not to fast, especially during Ramadan in the summer. So this is actually a more recent paper from Saudi Arabia at Ramadan on chronic heart failure, and you're going to see this really very amazing finding. During Ramadan, the functional class improved, this is Ramadan, from functional class 2 to functional class 1 in the majority of patients. 60% of patients actually improved their functional class due to the abstinence and reduction of fluid. So while the congestive heart failure data from these studies cannot be extrapolated to more advanced functional class patients or sicker patients, these are also in the Middle East and Gulf. Very important when you look at northern hemisphere countries like European or American countries, the duration of fasting sometimes in Sweden can be up to 20 hours. So again, stable heart failure patients, not a problem. Patients on unstable heart failure trajectories, recent hospital admissions, don't fast. What about medications? The reason for the pre-Ramadan counseling is important for medical advice. The thrice-a-day medications really have to be changed to single or sustained release formulation. Dehydration and electrolyte imbalance associated with diuretics is very important. Diuretics are actually not a good choice in the fasting patient, and diuretic dosing will need to be systematically down titrated during fasting, especially loop diuretics, especially in the summer months. Most of the heart failure medications, except for valsartan sacubitril, are once a day. So it is very important to remember that diuretics at high doses are a relative contraindication, especially in the heart failure patient. Finally, I'm going to talk a little bit about warfarin. Warfarin, Ramadan fasting does not adverse the efficacy or safety or oral anticoagulation. There are several studies that looked at warfarin therapy over a long period, comparing patients who fasted and patients who didn't fast, and thromboembolic events did not have any difference on the efficacy or safety of oral anticoagulation. So in summary, who should not fast? It's actually a fairly small group of patients with cardiac conditions. Those are patients with acute cardiac illness, such as a recent acute MI and ACS within the first 3 months, patients with uncontrolled hypertension with multiple dosages during the daytime, patients with severe heart failure requiring high doses of diuretics refrain from fasting. And finally, Ramadan is an ideal platform to target year-long lifestyle modification to ensure whatever healthcare benefits have been gained during this month are perpetuated. And this way, at this point, I will rest my case and submit again that this patient should, with his risk factors, and most patients with stable cardiovascular disease and diabetes should be allowed to fast within a structured program. Thank you.